Perfect. Thanks, Steve. And this evening, on behalf of the Practice Management Committee, we're really excited to have our first webinar tonight on a real hot topic among the membership in the Shoulder and Elbow Society, and that's the concept of doing outpatient shoulder arthroplasty. My good friend Quinn Throckmorton's done a wonderful job of getting together a group of experts to talk to us about how we can start incorporating this into practice, and if we're currently doing some outpatient shoulder arthroplasty, how do we optimize the results for our patients? So with that, I'm going to turn the webinar over to Quinn for this evening. Quinn?
Well, thanks, John, and thank you for all your work in putting together this task force to focus on the business side of medicine, which is something that that I think is a real advantage that our society can delve into a little bit and educate our members a little bit more on. I'm really delighted to be joined by our faculty this evening. We have 4 leaders here in the outpatient shoulder arthroplasty space. Really happy to have Anshu Singh from Kaiser Permanente with us, as well as Pat Denard from the Oregon Shoulder Institute, Tony Romeo from Chicagoland area, and Jason Coe from North Shore in Chicago as well. And each one of these guys has really done terrific work in advancing outpatient shoulder replacement and getting us to a place where about 10 years ago, this was thought to be dangerous, and now it's become accepted practice through really throughout the United States. So really excited for them to share with us their insights and their experience. So we're going to start with Anshu. He's going to talk to us about how do you prepare or set the table for your to transition your system to outpatient shoulder replacement.
All right, thank you, Quinn, Dr. Sperling, the ASES, and the panelists for allowing me to share my thoughts about this. Well, why is this not advancing? Give me a moment. Okay, here we go. So I do have an interest in some companies that do patient tracking and data, but I think my main issue is that I'm very biased towards total outpatient total shoulder in my practice. We'll go over the why. Is it safe? Why the surgeon has to lead, and then 6 steps to creating a sustainable program informed by what we did here. So is it a good idea? You know, when Quinn, myself, and some of the panelists started doing this, we really had to make the case on these kinds of webinars, but I think COVID has proven to us that if you want to be a productive open shoulder surgeon, you have to do things in the outpatient setting, I think. Most of us like to operate in the outpatient center for control, for surgeon experience, for patient experience, and financial considerations as well. I think patients are generally happier not being woken up at night by alarms on the ward. And there's a sense that you're offering a higher sort of level of care if you have an outpatient program. You also don't have to round, which is nice. In my practice, this has really been a reallocation of resources from inpatient to outpatient. Now your PA or you can call the patients much more efficiently from home or from a desktop. I often will call my outpatients on my way home after my OR day. And I think, you know, for me, this really elevated my ability to provide all shoulder care, right? Anytime you're thoughtful about what you're doing, your pain protocols, opioid reduction, it really makes you better throughout the spectrum of shoulder care. Is it safe? I think, you know, I'd be remiss if I didn't mention Quinn won a NEAR award for a matched case control study looking at 30 outpatient total shoulders. That seems like a small number now, but in 2016, that was really novel, and it really his proving that this is safe really set the table for others doing this work. So we created a program here at Kaiser led by a lot of our ASES surgeons. During COVID, this really accelerated quickly. And now, you know, we do like 75 to 80% outpatient per month across the system. And this is a big number. It's like 200 cases a month. And in terms of outcomes, you know, we do track an average typical month, you know, how many return to cares, how many ER visits and things like that. And it's been the same or better. This was published by Ron Navarro a couple of years ago. And this is something we recently submitted, but is not published. We looked at just our ASA 3 cases. These are the gray area cases. We did 1,800 of them over 3 years and compared the same day to the inpatients and found that, again, the same days did the same or better. These are same day discharges from the hospital. These are typically not patients who take in the ASC setting, but it showed that, you know, a surgeon's judgment is pretty good at, you know, keeping outcomes optimized. So it's super, super important that the surgeon leads. You know, a lot of people said it in a lot of different ways, whether it's the burden of craft, that the surgeon is a method. Even though we're not talking about a technical procedure, the surgeon is really the critical person to making this whole thing go. We have key relationships across the spectrum with all the key stakeholders. And I'll just give you one example. This is one of our hospitals in our system. 2 ASES trained surgeons, you would recognize names, but they're kind of laid back. They say, hey, let's see how this goes for everybody else before we jump in. COVID started, they jumped in, and you can see once those 2 surgeons agreed and decided to proceed, their numbers completely changed, and now they're 60 to 80% per month. So this is how to start. These are the 6 steps I would give you to start. One is you need a data stream that you can follow and iterate on. You need everyone pulling in the same direction. You need a protocol, a clear line of communication with your patients and you or your staff. You need to know how to pick patients and manage expectations. So I'm going to go through all 6 of these. So prospective data tracking is critical. I would say pick the minimum amount of data that you can reasonably digest and access. If you pick 20 things to go after, you'll probably be spinning your wheels, be difficult to get meaningful numbers. I think ER readmissions, basic complication rates, patient satisfaction is all you really need. And follow this every month or every quarter when you first start, and iterate on this, right? If you can't measure it, you can't manage it. If you can't manage it, you can't improve it. So this is key to being safe and having an effective system. You need to seek allies within admin, nursing, anesthesia, your PA, case coordinator, that kind of thing. It's really difficult to do this on your own because, again, you don't have people in the hospital supporting you. You kind of have to have that structure, and you have to make the case. In our system, we had, this is actually a lot easier now after COVID because we have Zoom, you have all these tools that you can use to meet virtually and get people on the same page. We have a care protocol. I use my health track, it's free. Force is great too. This is our internal Kaiser protocol. It's really, really critical that you're thoughtful about this and give something to patients, in their hand that they can access. So this is just some pages from ours of some patient education, some questions and answers, and medications and things like that. We follow the ERAS protocols, so 6 hours of fasting, 2 hours clear fluids. This does help patients to present in a more fed state, and this is validated in the anesthesia literature. The multi-modal ERAS pain protocol is fantastic. We use that in addition to, most of us do a single shot interscaling block, and it's been working out really well for us. So we actually put it into Epic as an order set just to make it as easy as possible for the surgeons, the multimodal pain. And that way, you want to enable people and not make this burdensome. Open communication. Patients really need to feel supportive, and either myself or my nurse practitioner will reach out to them the day after surgery. There's a lot of ways to do this. Some of my colleagues have total joint coordinators that take care of this. But I will say that the place where I've had this fail is that someone on the care team will be off message. In the first few months, I had a nurse in the PACU who literally said to 2 patients, "Oh, Dr. Singh made a mistake and wrote for you to go home. I'll have him change the order." And the patients freaked out so much, I just ended up, admitting them. So you really need everyone to have to be aligned in their communication with the patient. It's critical. Patient selection in the white is the original selection criteria for outpatient for me. The blue is kind of how I've broken the rules, and those patients I'll tend to do same-day discharge in the hospital, maybe not in the surgery center. So, we've softened quite a bit on age. If someone's a really well-controlled diabetic, if they're well-controlled COPD, basically if their disease state is well-controlled, these are the ASA 3 patients, we will do them in the hospital as outpatients. The healthy ASA 1s and 2s we'll do in the ASC. And then patient expectations, when we first started doing this a few years ago, I thought about, gosh, is this a patient I can do in the outpatient setting? Now my thinking is totally different. Is this someone I have to do in the hospital? So I think once you set up the structure, it's going to enable you to really have this mindset. And it's interesting. We did a pilot before we started of a few patients and really got their feedback at 1 month and 3 months. And we found that patients actually asked for more education. Here's that pilot data. And these are just a couple of the patient responses we got. They wanted more detail. They asked for a video, for a Facebook page, and didn't do that. Provide information. We want a class, right? Patients actually want that, and they want to feel comforted. And oftentimes, that's very, very reassuring for them. So this is some of the things I say to my patients when I have the pre-op conversation. I tell them, look, you're not a sick patient, right? So we're not going to treat you as a sick person. Our goal is to manage your pain, not zero pain. That's a bad promise to make, right? They should expect some level of pain so they don't come back to the ER. And then, I tell them, gosh, you already had a bad shoulder for the last decade. You're going to have a bad one for another month or so here. So you already know how to navigate your home environment as an injured person, right? So these are some kind of things you can say to reassure them. And in my experience have been really helpful. So in summary, I think this can be your default way of practicing. We're at about 75% system-wide. I think it's safe. The surgeon must buy in and be the leader on this, or it's a non-starter from the beginning. I think it's a win for essentially all parties involved. And yeah, look forward to the rest of the talks. Thanks, guys.
Thanks, Anshu. That's really good work, and appreciate everything that you've done to push this forward. Just some housekeeping. We have a pretty good group online here that's following us, and this is meant to be interactive. We have about 20 minutes of Q&A built into the end. So everybody online, please feel free to share any questions you might have in the Q&A feature, which is at the bottom of your Zoom screen. And Dr. Sperling and I will go through those and try and pitch those to the panelists here when we get to the end of our session and do the Q&A. So next, we're going to talk about the day of issues. So Anshu has set the table, but now Pat Denard is going to talk about the day of, the mechanics of outpatient total shoulder replacement. Excellent.
So Anshu really teed me up really nicely for this. And some of this is going to be redundant, but I think that, what's nice is we're saying very similar things. So I'm going to talk about the mechanics of shoulder arthroplasty. My disclosures are not relevant to this topic. So my practice is probably extremely different from Anshu's, in that I'm in a small rural aspect of Southern Oregon, and many of my patients have to come from very far away. They come from a 5-county service area, drive very far, and they're elderly, and relative to Southern California standards, much less educated. And I present that to you just to really reiterate what Anshu said, is that much of this is really about education. For us, we have a very low length of stay when we look at our Medicare data, especially for people who do over 100 a year. And when we look at our data post-COVID, we found that we are now discharging 87% of the patients home the same day for a primary shoulder arthroplasty. So my guidelines for hospital stay are pretty simple. It's really help at home. If they don't have that, they got to be in the hospital if they're walker dependent. And then I have very simple medical guidelines, as you can see here. So again, we've really simplified that. So the day of, I think the biggest thing from a technical standpoint, if more than all the protocol stuff, is you got to make sure that you're doing this procedure in less than 2 hours. We know that over 2 hours is a risk factor for infection. So I think that ideally you want to be shooting for getting to where you're doing this procedure in an hour, so you can get these patients home effectively. But any more than 2 hours, I would really advise that you're doing this overnight. What Anshu said is absolutely correct. You got to get alignment by setting expectations at the beginning. Mechanically, though, afterwards, for the staff, it's important to me that you do not send the patients to the floor. So we recover them in same-day surgery. And most of my patients are not at the hospital because I'm doing 70 to 80% Medicare in my environment. So it's Medicare considers an outpatient procedure, but I still have to do it at the hospital. So we don't send these patients to the floor, because once they go to the floor, you're going to have the nurses not be highly motivated to do the paperwork to send the patients home. I think it's critical you give the staff the detailed outline of your program so they really feel confident, because you have to have that buy-in from the nurses in the recovery area that the patients are going to go home. And I let all of those nurses know that I call the patients the night of surgery to follow up with them, so they know that the patient's going to be checked on. You got to develop the program, and I'm going to go into my details of what we do the day of the surgery. And it's really important you're captain of the ship and you really give detailed information to the patients and control the medical barriers. So these are those barriers you need to control. You got to deal with pain, nausea, constipation, hematoma, and infection. So we know if we look at readmission, this is relative to rotator cuff repair, but I think it applies for total shoulder arthroplasty. If we look at readmission, many of these factors you can see here, pain, constipation, nausea, vomit, urinary retention, this is all due to narcotics. So the single biggest thing you need to do is limit narcotics. This is our pain protocol. We also use a multimodal approach, giving patients preoperative Celebrex, Tylenol, interscaling Neuroboc with Decadron. We did use liposomal bupivacaine for some time, but we did not find substantial benefit for that with that. And we had big pushback for our hospital. And then post-operatively, we schedule Tylenol, we schedule ibuprofen for 5 days. We give them gabapentin at nighttime only, starting the second night for 3 nights. We find that just helps them to sleep a little bit, have a little pain control at night. There's not evidence to guide that, but we found that's effective. And then we send them home with 20 oxycodone. 30% of our patients with this protocol do not use a single narcotic. If they need a refill of oxycodone, I tell them they're only going to get 10. I would say, though, simply saying something such as 30% of our patients do not require a narcotic is very empowering to the patient, really helps them buy into this concept that it's not a very painful surgery. Nausea, your best thing here is really prevention by limiting narcotics. Well, we have the patients get a dose of steroid and Zofran. We screen to see if they have a history of seasickness, and if they do, we give them a scopolamine patch. If they've had a history of post-operative nausea that's been resistant to Zofran, we will also give them a MEND preoperatively the day of, and I'll give them a prescription for that, and they will pick that up and take that in the morning prior to surgery, and then post-operatively, I send them home with Zofran. Constipation, this isn't a barrier, but it's certainly going to impact the patient experience. You want to, again, limit narcotics, educated about it. I actually had my patients start a stool softener a couple of days prior, just to sort of be preemptive about this, because we had a few patients come back. Hematoma, there's a lot of literature on this now. You obviously have to have careful hemostasis, but we now know that TXA 1 gram, which is what we use IV, is safe. Several studies have looked at this and found this to be very effective. Of course, you can give it topically, but we're also giving other agents topically, such as vancomycin powder. So I like to give this IV, and I like to do it a half hour prior to incision to really limit the bleeding up front. Infection control, this is where, you know, it gets a little bit, there's variability in evidence, and maybe I am a little bit on the voodoo side here, but I give them benzoyl peroxide 3 days prior. I do a hydrogen peroxide wash before incision. I give ceftriaxone, vancomycin IV. We can debate on that, but the reason I like ceftriaxone is because you have the 24-hour, you have a longer half-life compared to Ancef alone. And I give them vancomycin powder within the wound, and then I put glue over the incision. I do think that is important as well. I think importantly, though, you got to recognize the patient goes through struggles from both the preoperative aspect to the aftercare. And we really focus on a lot of times the surgery and don't give them enough information afterwards. So what we try to do for us is we try to give them really detailed information. So we have a document like this that gives them a checklist for prior to surgery. It begins a month prior, you know, start getting your ride ready, stop taking aspirin a week prior, et cetera. So they have to go and check off all these things. This really helps set their expectations about what to expect, gives them confidence, but also they know what to do when they go home. And we also give them a preoperative physical therapy visit when they get fit for their sling. Same thing goes with the medication. We get really detailed. And, you know, if you just tell people take Tylenol 3 times a day, they don't know what that means. So we get granular and say, okay, you're going to take a dose at 7 o'clock. You're going to take another dose at 2 o'clock. You're going to take another dose at 10 o'clock. You got to outline it very simply for people, because we think about this all the time, but the patients don't necessarily. Same thing goes for rehab. So when they go home, the patients will ask right away, what are they going to do for rehab? So we give them a form that gives them their surgery date. We fill in the date that they're going to take their sling off, not say 4 weeks, but we actually write the date down in the form because they won't remember what 4 weeks is. And this is my protocol. You can use your own, but I think it's important that you're very specific about when you want them to advance. I think COVID really has changed how we have done things, just as other events have changed history. But I think from a healthcare perspective, we're going to look back and really see that it's changed how we deliver healthcare. You know, and our focus really pre-COVID was just trying to get patients out. After COVID, it really opened up some doors because patients were more resistant to be in the office, where we started also seeing increased use of telehealth and the adoption of remote monitoring technologies. So really our focus has shifted from getting into the outpatient environment to really improving the interaction between us and the patients while we are in the office. So we're trying to be present without being there. And I think this is a natural extension because, as we know, reimbursement's going down and we have to be in the operating room more, but we still have to provide care to our patients. So we've tried to leverage some digital technology tools to provide this information, because one of the keys to successful outpatient shoulder arthroplasty is educating the patients, as we've gone over. So we give them this information that I was showing you in app-based format that really gives them these checklists that they can go over so they can plan for surgery and hopefully minimize adverse events. You can also use this to coordinate their rehab post-operatively. So this is an example here what a preoperative experience would look like. The patient can log into their app and they can check off all those things that I showed you before. Here's your tips for today. Here's your home exercises, etc. To set the expectations, and then post-operatively they can check how their pain's doing, etc. Are you icing? Did you take your Tylenol today? All those sorts of things. We have found using tools like this that this has reduced calls to our clinic, 59% reduction in calls compared to prior, and our time on calls reduced as well. So there's a pretty big cost or time savings for our staff, which is huge in the environment when we are understaffed. One benefit is that these remote monitoring codes that uses this technology are billable. So there is some potential for increased reimbursement. This is only Medicare that this is related to. Another tool that you can use to control therapy post-operatively is to use this with therapy platforms such as this one, where you can do the same sorts of things and engage patients doing therapy at home. And I think this is a nice way also to be able to control what's really going on and have an extension of you without being there. And again, these are app-based tools that help patients go through and also have some potential financial thing. But that's, even regardless of the financial aspect, I think these are tools that can help us really administer care. So in summary, outpatient shoulder arthroplasty, you've heard, can be done safely. Setting patient expectations and creating a detailed program is the key. But I think these mobile app-based care management tools, remote monitoring, can really help facilitate the transition for you. Thank you.
Thanks, Pat. That's really detailed stuff and great use of technology to move things along and speed adoption, in addition to what you mentioned with the COVID stuff. And really impressed with your opioid protocol, your pain program. I think I saw Natty Hammond on this. I would like to recognize his work as well. He's done some outstanding work with opioid sparing and opioid free protocols. So Natty, thanks for tuning in tonight and sharing your information with us. Next up is Tony Romeo. So we're going to talk about outcomes now. We show you still being muted, I think, Tony.
We see your slides, Tony. We just don't hear you yet. There we go.
Sorry about that.
Yep, perfect. Thanks,
Good.
Tony.
Okay.
Perfect.
Everybody else is nice and smooth as usual. I'll give a little bit of a hiccup here. Sorry about that. So great talks. I agree with all the concepts that have been talked about. I will hopefully try to clarify a few things when we talk about outcomes. But the bottom line is that if you have the same healthy patient in the hospital and the same healthy patient in an ambulatory surgery center, the results are the same, the cost is less, and patient satisfaction is higher. Bottom line. The question is, who should not be in the ambulatory surgery center, as has already been discussed. So this is our talk tonight, and basically these are my disclosures. The biggest disclosure that's not on here is that I am the Executive Vice President of Musculoskeletal Institute. So I have to manage 45 orthopedic surgeons and 5 spine surgeons, and we have financial responsibilities to ambulatory surgery centers, as well as hospital co-management relationships. So we have to figure out what's the proper environment or ecosystem for caring for our patients. And we'll talk about that as we go along. We also have to talk about the surgeon's factor. It was already brought up, and so I'm just going to say it again, is that a lot of people that don't do a lot of shoulder replacements do not want to do this operation. That turns out to be more than 70% of everybody doing shoulder replacements. So we've got to make it easier, more comfortable, and more appropriate for surgeons who have lower volumes to successfully move these into an outpatient environment. And it looks like that the sort of the threshold, can you hear me okay? Oh, sorry about that. The threshold is about 30 cases per year, or somewhere in the neighborhood of 2 to 3 cases per month to really be able to get this all worked out in the system. Now, you heard our first speaker from Kaiser talk about outpatient, and I want you to be very careful when you read the literature on this. Outpatient doesn't tell you whether it was done in a hospital, a specialty hospital, or an ambulatory surgery center, and they're different. And they have different ways to look at things, different incentives, and you have to be sure that you understand, because the difference is not just the environment, but it's the cost too. I mean, there's a dramatic difference in the cost of doing this in the ambulatory surgery center. The question is whether the government's actually going to pay us for that. So outpatient shoulder arthroplasty outcomes, we started publishing about this almost 10 years ago. One of our hip and joint replacement surgeons started publishing about outpatient joint replacement in 2001, with his first large series on knee replacement in 2003. So heavily influenced by Dr. Berger to move these cases out of the hospital and into an ambulatory surgery center. And we were able to show from the very beginning, and over and over again, as Tom and others have shown, it's safe if you choose the right patient. That's really the key. And when you look at the MEDICARE data set, which is hard because that's mostly outpatient, it is outpatient hospital-based data, so it's not ambulatory surgery center. But the bottom line is those patients that were kept in-house are the ones that have more complications and problems. And we'll talk about the ones you really have to look out for. So there's been many reviews, and already systematic reviews for something that really hasn't even been around 10 years, really. But everybody's trying to really show that this is a safe thing to do. And you can read this literature over and over again. If you choose the same patient, same comorbidities, ASA 1 or 2, you're going to have the exact same clinical outcomes in a hospital or a specialized hospital or an ASC. The question is, what's the cost? And the question is, what's your patient satisfaction levels? And we think the closer you get to ASC, the better off that you're going to be. There are some unplanned stays for all of these, but they're not remarkably worse for ASCs if you choose the right patients. So in one of the most recent reviews out of Harvard, where they are not, I would say, one of the leaders in developing outpatient joint arthroplasty as their forefront. This is more about a systematic review, but they showed quite nicely that the rates of complications after outpatient shoulder arthroplasty were very acceptable. And the weighted average actually suggested it may be even less than it is in the hospital-based patients. And in terms of readmission rate, this is a paper that one of our past fellows did at Ohio State, shows that the readmission rate, no significant problems with doing it as an outpatient. In fact, it was less. Again, because the patients are picked. I hear all the time, well, you're cherry picking the patients. Of course we are. That's exactly what we're supposed to do if we're going to put it in the ambulatory surgery center. You want to cherry pick the right patient. And then when you look at outcomes with regards to cost, it's starting to be close. Now, complications, no significant difference between outpatient versus inpatient. In fact, some show less complications, but I would argue that they should show less because you're choosing healthier, safer, more patients. It shouldn't be based on this as whether you do them in that environment. It really should be based on the weighted average of the complexity of the patient. Here's another one where no significant differences. A couple of papers that I was involved in, outpatient versus inpatient anatomic shoulder, outpatient versus inpatient with reverse shoulder arthroplasty, no difference. Again, we are picking the right patients for our ambulatory surgery center. These are not in a hospital. These are actually ambulatory surgery center patients. Inpatient versus outpatient shoulder arthroplasty, a propensity score to really look at the safety of this. And actually, what was remarkable, if you look at that lower chart there, the adverse events were actually lower in an outpatient, again, which you think, but what Gus and his team showed that it can be safely performed outpatient. In the past 5 years, the proportion of outpatient shoulders from the NSQIP data has increased fourfold, as we're seeing from the data that was suggested at Kaiser. It's going to be even higher over the next few years. And currently, patients have selected for outpatient typically have less comorbidities. What about the patient's perspective? We're all being graded on that and judged on that. Absolutely no question. How would you describe your experience with outpatient total shoulder arthroplasty? Excellent, more than 80% of the time. How satisfied are you? Very satisfied. If you had another total shoulder arthroplasty, would you have it done as an outpatient or an inpatient? 94% outpatient. Okay, that's what your patients want. So that's what we need to do. And that's what we have to work towards. And the data is very clear if you choose the right patient. So pay attention to the exact patients that you're selecting. This is important because looking at the odds ratio for risk, one of them is age. The older patients, our numbers during COVID crept up from 70 to 75 to 80, even in our ambulatory surgery center. Females seem to have more problems than males in almost all studies. 1s and 2s ASAs are pretty much safe in an ambulatory surgery center, not just hospital, but ambulatory surgery center. There may be some social determinants that may affect your environment, so be careful, as someone already mentioned, about where they're going home to. And then in terms of other things, we know diabetes, uncontrolled diabetes, big mistake to put that in an ambulatory surgery center. You don't know what's going to happen, and there's all sorts of problems. Smoking, big problem. And for us, one of the big things that we always forget about is obstructive sleep apnea. And we really need to ask about that, because even if we're just giving a few narcotics, it's important that we don't put our patients in jeopardy. We need to really worry about that. Here's the NSQIP data, the latest data we have in terms of the annual volume outpatient anatomic shoulder arthroplasty. For you that are on the line that are doing 5% or 10%, and you can't do that anymore. They're all moving to outpatient. PAT's up to above 80%, almost 90%. For our anatomics, we're above 70%. Reverse is less because most of them are Medicare. And I'll just make a final comment about that, but you can do a reverse in an ambulatory surgery center. You can even do revisions. So there's times when it's a simple revision, and you can do a revision shoulder arthroplasty where you're not expecting much blood loss, and as Pat said, less than 2 hours. And you can do this in this environment very safely for these patients. And you can do a reverse, and again, from the patient's perspective, the reverse, the disadvantages, they are typically sicker patients, but not always. And the complication rate just in reverse overall is higher. So we just have to be careful about how we select our patients. But again, when we looked at this, and JP and Warner looked at this again, it was a very nice ratio. The final comment I want to make about this is that the surgeon is the method, has already been mentioned. You need to do these cases under 2 hours. You need to have a system set up in a very close relationship with your anesthesiologist. That's critical. And you need to choose your patients carefully. Don't take risks, especially in the ambulatory surgery center, and you'll have great results, and your patients will think the world of you. Thank you.
Outstanding work, Tony. Thanks for sharing all that. And excellent point. I think we'll delve into it a little bit more in the Q&A about the different settings of the hospital versus the ASC. I think we can drill down on that a little bit more. Our last speaker is Jason Coe. As we're fond of saying here in Memphis, we don't always know the question, but the answer is money. So he's going to be talking about insurance contracting and the business aspects of outpatient shoulder replacement.
Thank you very much, Quinn. Let me share my slides here. And here we go. So I'll be talking about the business of outpatient total shoulders and some of the insurance contracting. These are my disclosures. They're available on the Academy website. As has been pointed out, I think it's important to recognize what you actually get paid for and where you actually get paid for it. So outpatient total shoulders, CPT code 23472, are only paid for in hospitals. The Medicare inpatient only, it was on the Medicare inpatient only list until January 1st, 2021. And they became Medicare outpatient, but only for hospitals. This has been an area of ongoing discussion, and I think will be changing sometime soon in the future. But currently there is no ASC reimbursement code for Medicare patients, which for many of us, myself included, and it sounds like also Pat and a few others, are a large percentage of our shoulder replacement population. The actual comment is X5 unsafe surgical procedure in ASC. I think that's patently wrong, but no payment is made. Remains on the outpatient list. Additionally, for your inpatients, they can have an unexpected rapid recovery. This is the way you can have an inpatient, somebody who coded as an inpatient, who is technically coded as an inpatient on the Medicare side, and send them home the same day. So outpatient reimbursement in the ASC setting is primarily for private payers at this point. Just a look ahead about money, CMS payments are likely to decrease in the ASC. So if you take a look at areas such as total hip replacement, in a hospital outpatient department, you're getting paid $12,558. In the ASC, $8,924. There's this comment is that there's adjusted pricing attributable to the implant. The device offset cost was $6,041. Now, currently, shoulder replacement, Medicare shoulder replacement in the hospital outpatient department is $12,593. That's for the facility. A parallel may be ORIF or proximal humerus, which is also getting a similar amount of money in the hospital outpatient department. But if you look at the ASC, they're only getting $8,600, which is 69%. You can actually do a hemi for fracture in the hospital outpatient department and the ASC. And again, you can see that there's about a 30% decrease in payment in the ASC environment, at least under Medicare guidance right now. So if you want to take a look at overall costs, and this is a nice slide courtesy of Quinn, who summarized some of the other data. In the ASC, the total charge is around $45,000. In the hospital, it's around $52,000. And the difference is likely due to differences in overnight hospital resources. The implant costs are comparable. So before you're doing any sort of business with regard to shoulder replacement, and particularly if you are going to be on the hook for the facility side, you want to be aware of how much your implant costs are. The implants is the largest part of cost. Depending on the study, it's about 25 to 65%. And so your entire margin, if you are looking for that, and most of us are, and most systems are, is going to be determined in large part by how well you control this part. There's a huge variety of implant costs. Actual cost data is restricted in many cases. The lower side of average is probably around $7,000 or $8,000. The published data, John Sperling had information in shoulder and elbow in 2019, and they said their mean TSA cost was $3,090. And Quinn's paper in 2020 in JAOS, for their bundle, their cost was $24,822, unbundled $28,405. So again, very variable. Some of these numbers are probably more charges rather than actual direct costs for the implant. Another area that you want to think about is if you are thinking about trying to offer outpatient shoulder replacement, you may want to offer this as a bundle. And this is a way that you can offer, basically complete care, including the facility fee, and typically care for a period of time afterwards. And the most of these bundle prices are around $24,000, $25,000 at this point in time. But again, financial success in these kind of situations is based upon a number of different factors. Obviously, you want to have high quality and safety, as Tony was talking about, and Dr. Singh. Basically, you want to know that you have good outcomes. You need to have alignment with your surgery center, a lot of discussion preoperatively, and incredibly important is to understand your actual costs. And there are different ways to do this. You can clearly look at your direct costs, and you should probably figure in some of your indirect costs, like through time-based activity, time-derived activity-based costing. Particularly if you're in a bundle and you're responsible for the whole episode of care, you need to understand your risk as well as your direct costs. And then, as previously noted, preoperative screening, both social and medical and nutrition-wise, and postoperative management are critically important. Now, for the specifics of contracting, you need to understand your relative power and importance. You need to understand where you have your leverage. What is your book of business, and what is that importance to your insurer? Now, what's clearly important to insurers is the lowest reimbursement, least possible cost, but they're often looking at the total cost over a period of time, not just the episode of care of the actual surgical procedure. So they're usually looking at high quality providers who are able to control their number of readmissions and complications. Another area to think about is if you're independent, is comparing it to the hospital systems. You have to understand their influence in the market. You have to understand your relationship with them, as Tony was talking about. Sometimes these have to be balanced against different competing needs. And you also want to understand, do they have the ability to obstruct your initiative? So if you want to do outpatient shoulder replacement, then you contract with insurers. You need to have enough cases to be worth an insurer's time. Typically, this is done by groups in partnership with their other lower extremity joint replacement partners, because outpatient total joint, the volume of shoulder replacement is probably not enough in a private practice environment. You want to establish your baseline costs. You can use EOB forms. You can take a look at your direct costs, and you want to approach insurers individually and basically show them your results and your outcome and your costs, and come up with a good opportunity for both sides. In terms of carving what the contract actually looks like, you want to carve out procedures and codes. This is not really a bundled payment, but oftentimes act as one, including a 90-day episode of care, includes a facility fee and implant. And again, as we talked about, the implant costs are really critical. The vendors are typically responsive, and particularly if you want to say, hey, we're going to give you a large book of business and consolidate our providers. Now, you may want to carve out TSA implant costs, and you may be able to get competitive implant pricing. This is, again, Quinn's work published in JAOS in 2019. If you are a hospital-based employee, you can still use this to your advantage, and you have to understand your relative power importance to the organization. What is your book of business? What is your partner's book of business? Your orthopedic colleague's book of business, and your contribution to the overall margin of the hospital. What you may or may not recognize is that most hospital systems, their profit or their contribution margin, if it's a nonprofit, is about, their overall margin is around 3 to 6%. Orthopedics provides a significant amount of margin, but if the implant costs are very high, that margin can be totally eliminated. So we can take a look at where the use of different medications, again, the discussion about liposomal bupivacaine, this may be worth it for some people. For us, it's been worthwhile to decrease our bounce backs and recover into the ED. But you can negotiate around this with the hospital system. You can also gain, physicians can also gain potential ownership around management of an outpatient joint program or creation of an outpatient joint bundle. And management of that bundle. And that is the legal way to do some gain sharing around some of the benefits of that extra margin that is created by your work for the hospital system. Another area that has been tested legally is shared savings around certain kinds of implants or specific targeted goals around quality, such as length of stay, or savings around accruing to the bundle saving. So there may be a way for you and the hospital to work together so that if you decide to consolidate around a single vendor or primarily consolidate around a single vendor, some of this benefits can go to you. So in conclusion, outpatient shoulder replacement is a very good business. It's very attractive to patients, as has been said again and again. It's attractive to payers because their overall costs decrease. It's attractive to facilities because currently they're still able to collect, at least the hospitals are still able to collect a very large, relatively large margin, but not have to keep these patients in the hospital overnight. I think another important thing is that this allows for more opportunity for value capture by physicians. We have more control. We can choose where we do our procedures now, whether it's the inpatient setting, the outpatient setting, the hospital, or the ASC. And this makes us, puts us back into the driver's seat. You know, where we belong for the benefit of our patients. Critically, implant costs are absolutely essential, and you want to look very carefully at this. You want to take a look at a lot of different ways. The implant vendors are willing to negotiate and will drop their prices, but if you do not look at it, they will keep them as high as they possibly can. And then the other component is managing your overall risk, not only medically for these patients, but financially. Managing both of those things is good business and good medicine. So thank you very much.
Awesome. Thank you, Jason, and thank you everybody for those terrific presentations. We have a fair amount of Q&A time built in here. I don't see anything in the queue right now, but if any of our attendees have questions, please share those in the Q&A, and we'll be happy to go through them. And I'm sure Dr. Sperling has some questions as well, but I'm going to go down the line and just talk about. I'm just going to ask each of you about your setting, because we have a perfect mix here. We have Kaiser Permanente, big managed care system. We have private practice in Oregon. We have a big medical group that with Tony, and then academic medicine with Jason. Each of these has different barriers and different opportunities. So Anshu, let's just start with you. Let's go down the line. Talk about the setting in which you do outpatient shoulder replacement, and what are the barriers and opportunities that are most important within your system.
Yeah, for sure. I think for me, I'm in a big managed care setting. I think interestingly, from a surgeon standpoint, there's not a lot of financial incentive. We don't have ownership in our ASCs, but certainly to what some other folks have talked about, like Dr. Romeo, there's certainly an institutional desire to get cases out of the hospital. Hospital time is like gold, and they want to use it for cases that only can be done in the hospital. So I think, I have to credit Ron and others who partnered sort of with the hospital group that leveraged our registries for data capture. And, I don't want to say made it easy. It's still ultimately on the surgeon, but the advantage of a system like this is, like, if I create something in San Diego and it works out well, for example, our handbook, it's a 45-page handbook for the patients. Myself, my partner down here did a lot of the work on it. We can easily distribute that across the system. So the advantage is that it's easy to share best practices. The disadvantage is there's not a lot of sort of incentive on the individual surgeon level. So I'm sure Ron is just crushing. Is he commenting right now? Oh, I saw you smiling. Anyway, so that's what I would say is the pluses and minuses for us.
Pat, how about you? And then we got Ron Navarro already rattling cages here. I love it.
Yeah, so I'm, as I said, I'm the exact opposite. Private practice. We do most of our cases at the hospital because of Medicare. We have a heavy Medicare population, so about 80% of my shoulder arthroplasty cases are at the hospital, and I do the other 20% that are commercial insurance at the surgery center. The surgery center is nice for us because we have, with several of the payers, have negotiated not a bundle's a bit of a misnomer, but for assuming the risk for the first 90 days, we get to share in the profit to the surgery center. So the surgery center will take 51%, and then the surgeon will take 49% of the profit after implants. So, in that environment, we'll get about 3x compared to what we would normally get from a commercial insurance patient. So that's nice. But the hospital has been fine once we taught them how to do it, and really pushed them. And now they're at the point where if I get somebody that's staying in the hospital, they get mad at me. They're like, because everybody's fighting for beds,
How about you, Tony?
When I was at Midwest Orthopedics, I pushed the outpatient shoulder arthroplasty. It was very easy to do. We had that culture there. More than 10 years ago, when the insurance company said, well, you can't do that, CMS doesn't approve it, we went directly to Blue Cross Blue Shield, which is our largest insurer, and sat with their chief medical officer. And as was already said, we said, listen, this is what we're going to do. We would like a pilot project. We want to do these cases here. We're going to collect this data. We're going to share this data with you, which includes both outcomes, but also patient satisfaction. And at 6 months, they said, sure, we'll do that. And at 6 months, they said, you guys just keep going. That was more than 10 years ago. And so then we just knocked off Humana and United Healthcare. We carved that out in our community and did all of that. But it takes that process. And if you're an employed physician, you don't have access to most of the revenue cycle management, and you don't have access to contracting. And for a multi-specialty group like ours, just to give you an idea, if you go to Blue Cross Blue Shield and you want to get pricing, you're going to give them 100 codes, maybe 5 are orthopedics, and one of them's not going to be shoulder replacement. And so the insurance companies are so much more sophisticated with AI right now. They're going to take everything that's not on their list that they approved for a decent price, and they're going to give you the basement price on that. And then you have to go back and carve it out if you have the ability within your organization to create that opportunity. And so these are the challenges that we have. Personally, the patients love having experience in sort of this boutique environment of an ambulatory surgery center. But if a patient is really sick and they have a lot of medical problems, they really appreciate the safety of the hospital. So I think it's like it's already been said, it's on the surgeon to take great care of the patients. It just turns out that a lot of the concerns that we had for shoulder arthroplasty, we've mitigated with a number of technologies. One, preoperative planning. That shortens your overall surgical time. You've got everything ready to go. 2, we use TXA, so you don't see that patient like Pat showed, we got blood all over the place. That helps minimize our infection rate. Number 3, our swelling net. 3, our anesthesiologists are gold. Everything's done with ultrasound. Our blocks almost seem like it's 100%. and they work fantastically. Our anesthesiologists are concerned about patient care, so they get upset if they hear the patient went home and got sick. And they want to know what happened. I'll call them and find out, and they get better. And so we really have focused on what's the best thing for the patient. And I believe that we start with, let's see if we can go to the ASC, and if we can't, well, let's do it in the hospital as an outpatient. And the way you do that there, which we did for many years, is you have to put them in the hospital. You have to do an admission process so that the Medicare information gets tallied so you get reimbursed. But as Pat does, we put them in a step-down unit. They don't even go to the floor. And if they look great, they go home. And I mean, we've done a number of patients in their 80s that way this past year because of COVID. It's worked out well. When I first came here, less than 5% of all shoulder arthroplasty was done as an outpatient. 18 months later, we're over 50%. And so where everybody has on board, we did the things that they've been told. Make sure you set up a team, make sure you have the education, work with your anesthesiologist, focus on the patient. And anyone can do this if you have enough ability to modify the system. As Jason said, sometimes in an employed environment, you don't have that opportunity, but I think even the hospitals are getting smarter about this. They know patient care is really critical. And you have to have people like Ron Navarro, who are sort of our leaders of the future, and figuring out how to work in that administrative environment as an employed physician and get the things that are best for the patient. It's a hard thing to do. Ron's an example of someone who can get those things done.
Jason, final words. I think this dovetails with Ron's latest question is how do we avoid the race to the bottom regarding reimbursements? I think that's something that Brad Edwards has brought up in some meetings as well. What do you think?
So a couple of different things, I think amazing points. And I always love these webinars because I learned so much from everybody here. So thanks everybody. And it's been fun to work on this. I'm in a large multi-specialty group, but in a nonprofit private hospital setting, private hospital system. And one of the ways in which and within our department is what we've done is try to avoid that race to the bottom by trying to capture some more of the value, even as a hospital employee, by working with the organization to say, we are going to share in the upside benefit from both these things. If we work with you to standardize our implants and drop our costs by thousands of dollars, we're going to split that money. Similar to the partnerships with insurance companies, you're going to say, we're going to save this and we're going to split that. And we will split that, split the dollars there. If we save on the bundle, we're going to split those dollars there. So there is some opportunity to capture some of that value. And even if you are a hospital employee, the fact that there are people out there who do have these other choices, it provides leverage. And so that allows all of us to win, and the opportunity for us to provide better benefits to our patients, because we are, now everybody's in the boat pulling the oars in the same direction. With regard to this idea of, there is some concern around potential decrease in reimbursement around the ASC environment. And so what I think is going to end up happening is that we're just going to have to be much tougher on our implant companies. The reason why hip and knee implant costs are so low is because there are so many done. But if we take a look at what's happening over the next decade, the number of shoulder replacement procedures is skyrocketing. And and there are so many companies out there now who are pushing their version. And I think what's going to end up happening is that there's going to be some commoditization of implant costs, and that will continue to drive that down. But unfortunately, Medicare is not in the business of paying people more. And everybody else seems to be pegging the dollars to that. Where again, the opportunities I think lie in is physicians being able to articulate, like Ron has at Kaiser, what we've done at North Shore is where if we are in the driver's seat, we can provide benefit, financial and health related to patients and to the system.
Tom, can I make one comment? I want to say, actually two real quick. The thing about the payment is real. I mean, Medicare is going to approve this as an outpatient procedure probably in January, but the reimbursement will lose $2,000 to $4,000 per case. So as the surgeon leader, obviously you can't do them here. I can't allow that. And not to be critical of anything else, but that's the same with new technology, like putting a balloon in the shoulder that costs money that we can't get back from the insurance company. And we can't do them in our surgery center because we actually lose money. And so there has to be some level. And as Jason said, you just can't go to the government, so you have to pay us more for the implants. It's not going to work. But our shoulder implants are minimum 50% and sometimes twice as expensive as the hip and knee replacement implants in the same center. There's something not quite right with that. So we've got to really work on that. One last thing is, in groups like ours, and I think Jason may have this too, when we deal with Medicare Advantage, we can do a population-based as well as Kaiser. Kaiser, of course, does this. So even if it's, we wouldn't make Medicare money in the surgery center, since we're taking risks for the entire cost of care, we definitely want them in the surgery center. That's going to save us 40% off the hospital. And so even though we would be reimbursed for Medicare at a number that would make it right, in our overall pot of money that we have to pay for our 10,000 or 20,000 or 30,000 lives, we want those cases in the ambulatory surgery center, or otherwise we're going to lose even 40% more money out of the pot. So some of these newer, higher level reimbursement things may help drive this even further into the ambulatory environment.
Yeah, those are great points. And one additional thing that we played around with at our shop is also bulk implant buying, and that's a way to drive down costs as well. And that we have a question in the chat about hospitals without walls, and we participate in that. So I think I can feel that. Hospitals Without Walls is a COVID era program. For those that may not know, it's essentially a waiver system through CMS where your ambulatory surgery center functions as an HOPD. So you get HOPD rates in your ambulatory surgery center. And it was great at the height of the pandemic. I think it allowed a lot of people to get their surgeries done. It is now basically on the way out. It's been suspended from the standpoint of they're not taking any more applications for it. And they're basically extending it on a quarter by quarter basis. They won't let you know until like 2 days before the quarter ends. So the latest guidance that we got is that it's been extended through the coming quarter, through Q3 2022, but it's going to sunset at some point. John, do you have any further questions?
I think Patrick had another comment to make. Patrick?
Oh, please, yeah.
Well, maybe more of a question of the panel, because one of the things I think what Jason said about trying to share in the gain, gain sharing is a term people don't use as much anymore, but with the implants is great. But what we found is that the hospitals now are to the point where they are trying to do their align with other systems or be very big and drive down implant costs. They're saying, we don't care about you as the doc driving down implant costs. We're taking care of that. So then they're just back to us just sending them home, which we want to do because we're motivated. So we haven't been able to get anything back out of that. I don't know if anybody else has any of their tips to how you try to align with them. But since so much of the cost is in the implant and they're controlling that now, it's just we haven't been able to make headway in terms of those programs.
Tony,
I think Tony, you can handle that. The way that I interpreted what you were saying is that you basically have service line control when you're a big medical group, and you. Yeah.
So Pat, as you know, it's leverage. So if you were more than one rock star, but you had a bunch of them, and you were involved with this big program, you have a better ability to go to them and say, hey, we'd like to stay involved in this. We think we can really, not just implants, but the disposables and all these other things. And as Jason said, indirect costs, we can help you with all of that, and they'll listen to you. But when you're a smaller player, it's sad, but on a piece of paper, you look like you're the same person that just finished their fellowship in July in terms of what they look at in terms of their overall value to the system. So if you do 10 shoulders and that person does 10 shoulders, it's equal, right? And it's really hard sometimes in these systems to get that. So like everything related to politics and therefore healthcare, it's relationship related activities. And the more leverage you have in that relationship, the more chance you have to discuss it. But as Jason said, we are definitely fighting an uphill battle, and the weight of that rock we're trying to roll up the hill keeps getting heavier and heavier.
Well, outstanding work, guys. Outstanding discussion. John, I'll turn it over to you just for some final words.
Perfect. Well, Quinn, thanks so much for organizing a fantastic session tonight. I'd like to thank all our faculty for their contributions. Really great discussion. on a very hot topic. This will be recorded, so it'll be an opportunity for other members of the society to hear. But I'd like to thank all our faculty members, thank Quinn, and thank for everyone attending tonight. Have a wonderful evening.
Good evening,
Thanks,
guys.
everyone.
Thank you so much.
Take care.
Take care.
Everybody.
Thank you.